This webinar is brought to you by the New Hampshire Institute on Addictive Disorder. You can access the recording of this webinar at our website listed below. The title of this webinar is the Trans-Theoretical Model, or also known as Stages of Change. And again, welcome. In terms of certificates, after completing this webinar, please upload and complete the quiz. If you're interested in receiving a certificate, you can find the quiz in the file pod throughout this presentation on our website, and it's listed below, or you can email the Training Institute as well. You can email, mail, or fax the completed quiz, and you can see the contact information below. If you are a member of NHADACA or NADAC / NADAC, the certificate for this webinar is free. If you're not a member, the fee is $15. You will receive a certificate worth 1 continuing education unit or 1 CE once you have completed and passed the quiz and paid for the webinar if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this 1-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Drug Use Professionals. In terms of technical support, if you have any trouble viewing the webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. And you can find this phone number on the bottom of the screen throughout the presentation. For any additional questions you may have, please email any questions regarding the material you see today at the email address listed below at the Training Institute. So without further ado, we want to start the webinar. Again, thank you for joining us. The topic today is the Trans-Theoretical Model, also known as Stages of Change. I will be your presenter. My name is Janet Hernandez, and I am affiliated with the New England Addiction Technology Transfer Center. You see my email as well as my phone listed there. In terms of a brief summary of who I am, I have worked in the field for 29 years in prevention, intervention, treatment, and recovery supports. I've worked in residential settings, outpatient settings, as a clinical supervisor, and as a professional trainer on many different aspects. I am also a person in long-term recovery. What that means for me is that I haven't used a drug or a drink in the last 30 years. What that has enabled me to do is to be a productive member of, first and foremost, my family, second, my community, and third, to be able to do this work on a daily basis. So I'm really happy to be here to share a lot of information with you over the next hour around stages of change, and I look forward to continued work with the folks in the New Hampshire region. Before we move on, I just wanted to give you an overview of the New England Addiction Technology Transfer Center. We're part of a national network consisting of 10 centers that are regional and 4 centers that focus on some very specific areas all across the country. We seek to raise awareness of evidence-based and promising treatment and recovery practices, to help people build skills to prepare the workforce to deliver state-of-the-art addiction treatment and recovery services, and to change practice by incorporating these new skills into everyday use for the purpose of improving addiction treatment and recovery outcomes throughout the country. You see our telephone number there, a contact person in the office by the name of Pam, and you can click on these links and go directly to our website. And so this webinar is co-sponsored by the ATTC, and we are extremely happy to be a part of this collaboration. Before we move forward, it's important for us to understand the context and conditions that we seek to change throughout the country in relation to substance use disorders, but very specifically here in the New England area and New Hampshire, we know that we are experiencing an opioid overdose crisis. And this is part of the context in which we seek to um, develop, increase, and promote change. Um, and so that begins with understanding the different substances that are available and their impacts at the community level, beginning with heroin. And we know that in terms of availability, the heroin seized at the border has increased from 500 kilograms during 2000, 2008 to over 2,000 kilograms in 2013. We also know that a bag of heroin is very cheap and accessible all over New England, including New Hampshire, and the prices range anywhere from $3 to $10, depending on the city, the state, that sort of thing. In contrast to the 1980s and 1990s, when a bag of heroin was really more expensive than what it is now, ranging anywhere from 20 to 30 to $40, depending on the year and again the region and location. And in terms of heroin, we are at an all-time high by way of purity, and it is impacting the work that we do. Another drug that's in the news a great deal is fentanyl. It was originally developed to treat pain in the US, and it's 50 to 100 times more powerful than heroin, and it's being produced illegally in labs all over the world. And so that drug is being mixed with heroin and or cocaine. And as of this last week, I was reading in the paper that it's also being mixed with marijuana. And so this should be alarming to all of us in the region. Another piece to this opioid crisis that we currently have are prescription opioids. Initially, we should understand that the industry argued that they were not addictive, and we should know that since 1999, sales have nearly quadrupled in the United States. We have overprescribed opioids for pain management, and there's a recognition of that. And it's easy access for family and friends. In other words, people get a prescription, they might have it in their medicine cabinet or at home, and as we can imagine, family and friends gain access that way as well. And for folks who develop problems with prescription opioids because they are so expensive and a little bit more difficult to obtain, they transition to cheap heroin, and they are used in combination with other substances. So, we're talking about combinations that are deadly, and we see the impacts of those. In terms of deaths in the United States, we know that since 1999, the number of opioid overdose deaths has quadrupled. Young people are disproportionately impacted by opioid overdoses. And we know that the data says that overdose deaths and availability of opioid prescriptions follow the same trajectory. In other words, as we began to make opioid prescriptions available for people, we also saw the increase of deaths by way of overdose. Approximately 91, maybe even more people die every day in the United States. So it means that today, as we speak, 91 people will die at the very least. And that is 33,000 people per year. We have surpassed deaths by car crashes and by gun homicides. And this is as of 2015. And we know that the number of deaths each year have gone up in the New England region and in New Hampshire in relationship to overdose. And prescription opioids continue to fuel the epidemic. Even though we're trying to get our hands around the number of people who have access to opioids by way of prescriptions and family and friends, we're still in the midst of this crisis. So, very recently a crisis is declared. Substance use disorder providers and advocates in the front lines serve their role in terms of sounding the alarm. Public health departments and providers across the U.S. responded and provided a perspective. We witnessed the rise of vocal advocates representing individuals and families from middle-class neighborhoods across the country, and politicians became engaged, and many developed talking points, policy positions, and they all promised to take actions. And the media also takes notice, and it's really interesting to talk about the media because many times their stories in the past have been sensationalized. And there is a sense that the media is doing a little bit better in terms of reporting the crisis, the deaths, and those sorts of things. Also, criminal justice systems and first responders begin to take action. Those are some of the first people who began to carry Narcan and other forms of reversing opioid overdoses and begin to refer people to treatment and to talk about the needs for treatment. We also begin to develop a number of policies and we begin to implement them, and resources are mobilized. One example of that is the Cures Act that was passed during the Obama administration, and in this current year, some of those dollars have been made available to the states and territories across the country to respond to the crisis. Another context for our work is mass incarceration. And before moving on, I just want to say that, we declared a crisis, as I mentioned in the previous slide, because the number of people who are dying. But we should note that people have been dying for decades as a result of opioids and as a result of overdose deaths and other issues related to that. It just so happens that we declare a crisis because young people from the suburbs who are affluent are also dying. And that is a primary driver for declaring a crisis. But we know that we've been dealing with an epidemic for decades. And we can see how this has developed by way of mass incarceration by understanding that 200,000 people in 1970 were incarcerated in the US. And today in 2017, we have 2.3 million people incarcerated. And so something is happening between 1970 and 2017 that we end up with that many people incarcerated in the US, and it's important to pay attention to that. Some estimates say that 80 to 90% of those incarcerated are addicted or have a substance use disorder or meet some of the criteria for having a substance use disorder. Upwards of 50% have a co-occurring mental health issue as well. And so, the prisons and jails in the US have become the largest provider of mental health services. And that should be alarming in and of itself, because I don't think that anyone listening to this webinar is interested in receiving their mental health services from a prison or a jail, but that's the system that we have currently in place. So what are the deliberate policies that have landed us where we are today? In 1970, there's a declaration by the then President Nixon of the war on drugs. We begin to see soon thereafter military interventions and the militarization of police in the US, but military interventions primarily in Central and South America, all under the auspices of the war on drugs. There are a number of crime bills in the 80s and 90s that were debated in Congress. You could not be elected in this country unless you had a posture of tough on crime, and that contributed to this issue as well. Both Democrats, Republicans, and independents were responsible for these crime bills. We also developed policies in relationship as a result of those crime bills of sentencing in relationship to crack and powder cocaine. In other words, you would get more time for small amounts of crack cocaine than large amounts of powder cocaine. And we begin to see disparities in sentencing there. We developed mandatory minimum laws, which are really intended to keep people locked up for a very long time without a really good reentry plan. Many of these people spend 5, 10, 15, 20 years in prison and then are released with very little supports and or services. And we also developed school zones and policies around school zones. And most major inner cities are school zones because they just don't include schools, they include daycare centers, parks, and it's 24 hours a day. So this adds an additional 2 years in some districts to the mandatory minimum. And these are, if you got 5 years mandatory minimum and add on a school zone, then and people end up doing 7 years, which is almost a decade before getting out. We also developed criminal offender laws, which are on the books, and these impact everything from housing to our ability to find jobs, to request student loans at the federal level. Um, just it impacts reentry, it impacts recovery in so many different ways. And we even, in some of this stuff, we took people's ability to make a living by way of taking their license. And so, if you can imagine, if it's difficult now to get to work and you have a car and a license, imagine if you didn't have those. And so, these are policies that were put in place. We also developed mass prison construction because we needed to house those 2.3 million people in the U.S. And many of those prisons were private prisons and or jails, and the services within those prisons and jails have also, to a large degree, been privatized. What it means, everything from the food to health services to phone privileges to just everything and anything within prisons are being privatized, and people, some people, are making a lot of money off of this situation. So none of this happened by coincidence. Other substance use issues by way of the context in which we're going to talk about change includes, alcohol. We don't talk a great deal that much since we're focusing on opioids about alcohol. It has been a problem, remains a problem, and we should be talking about all of these substances and not just one. Cocaine, very similar, methamphetamines in large parts of the country is a big issue. Marijuana, in our region, there are a number of states who have passed laws around recreational marijuana, and we haven't done a really good job, in my own opinion, in terms of developing policies around marijuana. And then there are a number of other issues that are part of the context in which we work in terms of other co-occurring health issues, we should understand and strive as we think about change and helping people make changes for the better, is that, there are mental health issues, there's HIV and AIDS, there's hepatitis C, or also known as HCV, and the CDC just reported that we have a 300% increase in new hepatitis C cases as a result of the heroin or the opioid overdose crisis. And there are a number of other health conditions. So when we think about change, we should think about it comprehensively in terms of co-occurring disorders and other issues that communities, individuals, families are facing on a daily basis. Another part of the context is what's known in public health as the social determinants of health. In other words, addiction and substance use disorders develop within a context, and that context is housing, education, employment, access to quality health, access to health care, um, and the criminalization of substance use disorders. And so when people say addiction is a brain disease, it has components of that, yes, but it also has components of the social determinants of health. And we cannot focus on one without focusing on the other, because if we only focus on the impact on the brain, um, and we only treat that portion of the substance use disorder and not pay attention to housing that is conducive and supportive of recovery, to education that really creates the conditions for people to learn, grow, and do better, for employment that's meaningful in terms of people making a living, and paying their bills and moving forward, in terms of a place where people can feel that they're productive in society. We will continue to make little headway in terms of changing the conditions that help people get better. So there's this context called the social determinants of health, and I want to emphasize that again and again and again. Uh, Moving away from the context just for a little bit, we need to talk about our current client profile and what they look like. Um, and we know that they're relatively young. Many of the people who are coming into treatment are relatively young, and they're diverse. And they're diverse not just in terms of race, ethnicity, and language. They're also diverse in terms of age, gender, sexual orientation, their socioeconomic status, religious beliefs, and many other areas as well. So the client population walking through the door at our treatment facilities is very diverse, and we need to understand that profile if we are going to effect change in a meaningful way. Moreover, many of them are using multiple substances and not just one. So rarely do we get the person who's walking through the door who just uses one substance. Um, there's a history of trauma. Some argue in the literature that way over 90% of the folks that we work with in the substance use disorder field have experience of trauma. I am of the train of thought that 100% of people who have used substances have experienced trauma. And so think about it: incarceration, poverty, abuse, neglect, experiencing homelessness, all of those things contribute to trauma in many different ways, which has implications in terms of how we treat people and how we help people change into the future. And again, some estimates upward of 90% of the folks that we work with are criminal justice involved because that's the policies that we developed way back beginning in the 70s. And so we ended up with 2.3 million people incarcerated. And I didn't say this earlier, but I just want to say it now. In addition to that 2.3 million people who are incarcerated, we have anywhere from 4 to 7 million people who are under probation, parole, some type of supervised home incarceration. And so that in and of itself means that most of the people that we are encountering um, also have criminal justice involvement. And if we are going to understand issues of change, we have to understand this important and complex client. They're challenging in multiple needs as well to this piece in terms of the client profile. Um, the state of the behavioral workforce is also important to understand within this process, and our workforce is staffed primarily by baby boomers, and they're retiring soon. The majority are white and not representative of the client population seeking services, and this is in many reports and research studies of the state of the workforce all over the US, and the Northeast region is a part of that. And there's a shortage of current staff, and we are in dire needs of recruiting new staff into our work field. There are a lack of training and professional development opportunities for existing staff, not to mention, people who will come into our system in the future. Our staff are underpaid and overworked and undervalued, and this contributes to, the difficulties that we're having in relationship to state to change. So that's the profile of the staff, as well as a profile or snapshot of the client population walking through the door and the context in which we do the work that we do. There's a context for stages of change and understanding them, and Prochaska and Di Clemente developed the model. And among many other considerations, they propose that individuals go through a logical series of decision changes on their way to adopting new behavior. And it's important to begin there by way of understanding how people change. And in terms of this context, we understand that change is a process and it's not an event. In other words, people don't change from one moment to the next. They change over time. It's gradual, and there's ebbs and flows in that change process. It involves cognitive and behavioral processes. So people have to think about the change that they want to make. They have to practice change, and they have to think about it some more, get some more practice. And so, in that way, change is dynamic. And change can be challenging, and most people begin there, oh, it's so difficult to change, but it can also be a very rewarding process. And in terms of trying to be strength based, we should focus on how rewarding change is as opposed to just focusing on how challenging it is. And above all, change requires practice and patience, not just on behalf of the person seeking change and making change, but on those of us who are responsible for promoting change, supporting change, and helping people to sustain change over time. Um, what can change? What can change mean to people who work in behavioral health? Um, for us who work in this field, there are opportunities to affect change at the individual level and promote recovery. There are opportunities to address health disparities and build health equity in relationship to change. There are opportunities to develop new skills and competencies as it relates to the change process. And there's opportunities to participate in micro as well as macro level of changes. And so some people are working individually with clients, and so that's rewarding, and we can participate in that. And or there are some folks who work at macro level changes, in other words, policy changes, advocacy changes, even organizational wide changes, and all of those are um, legitimate forms of change that we can and should be participating in. Here's a discussion question as we move forward. In 2017, there are 200,000 people incarcerated in the US. Please select A for true or B for false. Thank you for doing that. Um, And so, what can change mean to your client population? Which is another question that we need to ask ourselves and answer if we're going to promote change in any in any effectual manner. So, one thing that they might think of is um, that change is challenging and unattainable. Remember, we get all excited about people getting better and changing and getting recovery and doing a lot better. But for the most part, when we start recovery, I can talk for myself here very briefly, is that I was afraid and I thought that it was unattainable. In other words, when I first heard the first person say, I have a year in recovery, in my head, I said, they must be lying. That can't be true. I've never met anyone in recovery that hasn't done drugs for a year, never mind 5, 10, 15, 20 years. So they might be thinking that it's challenging but unattainable. They can also be thinking that it's scary and confusing. What is this thing called change? What am I embarking on? Is this something that I want to do? I've never done this before. We should think about any time that we wanted to make change, that it can be confusing, it can be scary, and people, can have one step forward, two step backwards type of deal. And this is a change from what they perceive as normal. And so let us always remember that our client population, if they're using substances, if they have been incarcerated, have lived in poverty, if they, experience homelessness, co-occurring disorders, that sort of thing, you have that in your life for a very extended period of time, 5, 10, 15, 20, 30 years. um, we begin to perceive that as normal. And so what we're asking them to embark on, which is a process of recovery, can seem alien and very abnormal. And so we should pay attention to that in the change process, by way of promoting change. Um, by the same token, change can be rewarding and life changing, and we need to be glass half full, and not just dwell on the negatives. It can be life-saving. I know that my life has changed dramatically, and I'm here today because of changes that were life-saving for me and my family. And it can be a process of liberation, and one can experience social justice in many different ways. And so it's not always how difficult it is, but also how rewarding it can be on the other end. What can change mean to your organization or program? Securing financial resources. The work that we do is financed either by grants or by reimbursement through health insurance and those sorts of things. And so organizations garner the resources to help change move forward. There are opportunities to recruit and hire culturally and linguistically competent staff. I'm talking about this here because if we're to change the current dynamics in our workforce and what's happening there, we need to pay attention to issues of diversity, disparities, and building health equity. There are opportunities to affect change at the individual level and promote recovery for organizations. It's also opportunities to address the social determinants of health that I talked about earlier. And it's opportunities to address health disparities and build health equity, as I said before. And so change can mean many different things to many different people: the providers, the clients themselves, and the organizations in which we work in. So we have to, I think, at certain points, take a step back and think about how we claim we treat people. And here, I'm not just talking about the we in the substance use disorder field. I'm talking about the larger we, health and human services. But obviously, those of us who work in behavioral health are part of that larger we. And so this is what I've heard over time. We are non-biased. Have you heard that? Have you said that? I have said that in the past. I try not to say that anymore. I am non-judgmental, or we are non-judgmental. Have you heard that? Have you said that? I have said this in the past. I try not to say it anymore. We treat people as they come. Have you heard people say this? Have you repeated it? I have in the past. I try to stay away from some of these terminology because I think that they're problematic. Many times we say, as we want to be treated. Have you said that? I've said that in the past. Again, I try not to say it anymore. And one of my personal favorites is we treat everybody the same. And respectfully, what I tell people all over the country in training and in face-to-face and through webinars is that all of this stuff that's listed here, all of these bullet points, are really a crock of shit. They are designed for us to feel good about ourselves. Because are we biased? Human beings are highly biased. We are highly biased. There are things that we like. There are things that we don't like. We have internalized mixed messages about the other. And whether we see it or not, biases are there. Are we judgmental? Of course we are. We are highly judgmental. And if you're sitting in your seat or standing right now and saying, I am not judgmental, well, you're judging me now. You agree with me or you disagree with me, and that is a judgment. Do we treat people as they come? This lasts about 20 seconds because we are agents of change and we promote change and we're responsible for promoting change. So as soon as people sit down and we bring out our treatment plan, our goals, our objectives, or everything that we pull out to help people look at their behaviors and change for the better, this whole as they come lasts for about 2 seconds. As we want to be treated, I doubt it that anyone on this call wants to be treated the way that I want to be treated because you are different from me and vice versa. And so we have a lot of similarities, which brings me to the last bullet point. But there are a lot of things that are different by way of culture, language, sexual orientation, socioeconomic status. And so we should not be saying that we should treat everybody the same because people are to be treated in relationship to what they bring and who they are. And so, my call here with how we claim we treat people is to embrace some of the differences, to embrace my biases, to embrace my judgments, to embrace those things as a way of understanding them better, and not deny that they don't exist. Because when we deny that things exist, things don't that they don't exist, things get worse, they don't get better. And so there are some definitions here, that and some distinctions that we should go through. And it's that those are things that, like, how do you define recovery? Because what might be recovery for me might be different recovery from you, and different to the clients in front of us. So sometimes we talk about recovery and we assume that everyone's on the same page, and not everyone is. How does the recovery community define recovery is another important question, because those definitions do vary from uh, person to person, program to program, and who we're talking to. How do our clients define recovery? If you've never done this exercise with clients, is ask them, how do you define recovery? And you will see that many of those definitions vary and differ depending on who we're talking to. How does society define recovery? We just said that we've gone through several decades of locking people up and placing people in prisons and jails. And so we've given this message to society that people deserve to be in jail. They don't necessarily deserve treatment. And so society might have a very different definition of recovery than what we have. Now, this is getting better. But in some instances, we are in very difficult situations. I'll give you one in relationship to how does our workforce define recovery. Well, some people in the workforce and some people from the recovery community think that if you are on any type of medication, that you're not in recovery. So think about how we've treated people who are on medication-assisted treatment historically, through methadone, or people who had a mental health co-occurring disorder, and we said, well, they're really not in recovery because they're taking medications for their mental health issues. And so a lot of these attitudes, beliefs, and behaviors are alive and well today. And let us never forget that our field has treated people punitively. When people have um, exhibited signs of their disease, we have kicked people out of treatment. We have essentially denied them life saving treatment just because they're exhibiting symptoms of their disease. And by the way, those of us who work in this field and are getting paid, and even if you do it as a volunteer, we took on a responsibility because we said we understand substance use disorders. So why would we be kicking people out or treating people badly because they're exhibiting symptoms of their disease? And so it's important for us to understand these definitions from the different perspectives and the distinctions that they bring when we have conversations with people at the community level. SAMHSA defines recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The four dimensions of recovery are health, home, purpose, and community. And so as we think about that and we think about health, we're talking about living in a physically and emotionally healthy, as well as overcoming or managing one's disease or diseases or symptoms in terms of health. Home, a stable, safe, and recovery conducive place to live. Purpose, so meaningful daily activities such as a job, school, volunteerism, uh, family caretaking, or creative endeavors, and the independence, income, and resources to practice in society. And then finally, community, relationships and social networks that provide support, friendship, love, and hope over a lifetime. So in terms of recovery, it's important for us to step back and think about what that definition looks like and what we're striving for. Another definition, which I find equally, if not more interesting than the SAMHSA one, is William White. And if you haven't been to William White's page, please visit it, williamwhitepapers.com. And so what William White says is the experience of meaningful, productive life within the limits imposed by the risks of addiction. Recovery is both the acceptance and transcendence of limitation. It is the achievement of optimal health, the process of rising above and becoming more than an illness. Recovery, in contrast to treatment, is both done and defined by the person in recovery. And I'm always struck when I read this piece by William White and his definition that we're seeking optimal health and achieving optimal health. And it's the process of rising and becoming more than one's illness. In other words, we have done a really good job at pathologizing people and calling people addicts and homeless and schizophrenics. And, um, you know, people are more than that. And actually, people are not those labels, but they become those labels when we give those labels to people over time. And here's a really important piece as well. Recovery, in contrast to treatment, is both done and defined by the person in recovery. In our field, we have tried to define what treatment is, and we've done a good job at that. But we've also tried to define recovery for people in contrast to allowing them to define what recovery means to them. And it's important for us to allow people to come to their own understandings of what recovery is and means to them because they get to do recovery in their own lives. There are many dimensions of wellness in relationship to change. And here are some of those dimensions: emotional, spiritual, intellectual, physical, environmental, financial, occupational, and social. And so when we think of change, we need to think of change in a comprehensive way, not in just stopping to use substances. That's a part of it. But that, as far as I'm concerned, is one of the most easiest things to do. The more challenging things are to think about change in all aspects of life and to incorporate those change processes in everything that we're doing on a daily basis. And that is a little bit more challenging than just talking about stopping to use one substance, for example. That these 8 dimensions that I talked about earlier, in terms of emotional, we're talking about coping effectively with life and creating satisfying relationships. In terms of environmental, we're talking about good health by occupying pleasant, stimulating environments that support well-being. In terms of financial, we're talking about satisfaction with current and future financial situations. Intellectually, we're talking about recognizing creative abilities and finding ways to expand knowledge and skills. In terms of occupational, we're talking about personal satisfaction and enrichment from one's work. Physically, we're talking about recognizing the need for physical activity, healthy foods, and sleep and rest. Socially, we're talking about developing a sense of connection, belonging, and a well-developed support system at the community level, at the family level. Spiritually, we're talking about expanding a sense of purpose and meaning in life. And so those are the 8 dimensions of wellness that we should always connect to issues of change. And so Prochaska and Di Clemente developed these stages of change, and they occur in 5 stages in terms of behavior change. The first one is pre-contemplation. And we should understand, all of these stages and what they mean a little bit further. The next one is contemplation. So how do you move people from pre-contemplation to contemplation, and then from contemplation to preparation, and from preparation to action, and from action to maintenance. And so these are the 5 stages that they proposed, and people in different stages are dealing with different beliefs, attitudes, and behaviors as it relates to substance use disorder, but also as it relates to the change process in and of itself. And so some of you right now might be thinking, so what about relapse? So if I may just go back to the previous slide for a quick second, you see that Prochaska and Di Clemente talked about 5 stages of change, 5 stages, not 6, but 5. So what about relapse? Historically, we've dealt with relapse in a punitive manner. That's the first thing that we should understand. Punishing people because of their symptoms of a substance use disorder. And so we've kicked people out of treatment. We've taken away life-saving treatment because people have relapse. Um, we should address, that said, we should address relapse at every stage of the recovery process, not wait until people relapse. So what does that mean? It means that very early on, we begin to address issues of relapse. Um, if and when a person has a reoccurrence or a relapse or a lapse, um, they do not have to start the recovery process all over again. There's this sort of belief that some people need to start all over again. Well, having a relapse or a lapse doesn't mean that people didn't learn stuff along the way. And so you don't have to start um, from the beginning. The person doesn't have to start from the beginning. And relapse does not have to be a part of recovery. And I think that um, part of what William White says is that um, there are many people who have never relapsed, but we rarely do studies on people in long-term recovery. We do a lot of studies on people who have had multiple lapses and relapses and episodes in treatment, and we can learn a great deal from people who are in long-term recovery who have never relapsed. Now, that said, there's a significant number of people who do relapse, and we need to attend to it. And we need to attend to it in many different ways. Um, and what we should be creating is an expectation of success and not an expectation of failure. So when we tell people relapse is a part of recovery, what we're really telling people is no matter what you do, you're going to relapse. And that doesn't have to be true. What we have to tell people is some people relapse, some people don't. What are we going to do to increase the probability that you don't relapse? And if you do, what's the recovery capital that you're going to have that's going to help to support and maintain your recovery over time? So in terms of that pre-contemplation stage, the key characteristics there is no intention to behavior change. The individual with the problem can be aware, unaware, or underaware of the problem. Families, friends, and neighbors are often more aware that the problem exists than the person with the problem themselves. And people systems will use influence, threats, and or coercion to produce change. And so think about what we've done by way of, telling people if you leave treatment or if you don't comply, I'm going to call your probation officer. I'm going to call your parole officer. I'm going to call your family. I'm going to report you. And so we've used coercion and threats to keep people in treatment. Um, and just being there doesn't mean that people have bought in. Many people just being there means that I understand that you have more power over me. In terms of the contemplation stage, the key characteristics here are the individual is aware that the problem exists. So now you move from not being aware to being fully aware that the problem exists. The person is also seriously thinking about making change, but has not yet made a commitment to that change. They're just thinking about it. In this stage, the pros and cons are weighed, and by way of that, we say, what's the problem and what are the potential solutions? And the key question that is answered here is what's in it for me, or the WIFM question. Without answering that question, people do not move on. I will not make meaningful changes in my life unless I know that there's something in it for me. In the preparation stage, the key characteristics are there's a development of behavioral intent and goals. And so people begin to think about what that change is going to look like. Um, they intend to take action within the next month. They may have acted unsuccessfully within the last year. Some behavioral changes may be observed, smoking fewer cigarettes, using less cocaine, delay of the first cigarette or drug use, those sorts of things. And the key element of this stage is behavioral intent. Just go back to that piece. In terms of the action stage, the key characteristics there's a clear goal, and it's to overcome the identified problem. In this case, substance use disorder. There's a successful alteration of the behavioral change, and the period of time is 3 to 6 months in terms of considering someone being in the action stage. So the mere action of showing up at a detox doesn't necessarily mean that you're in the action stage, or making a call to a treatment center. That's more preparation than being in action. The individual makes modifications to behavior, experience, and or the environment, and it involves overt behavioral changes. In other words, people are out. If I'm in recovery, I tell other people that I'm in recovery, because how else would I receive support and guidance if I'm not out and being overt about the changes? And it requires knowledge, commitment of time, energy, and resources. In other words, recovery capital. And in the maintenance stage, the key characteristics are a continuation of newly adopted behavior for more than 6 months, engaged in recovery processes, have a support network in the recovery community. They have recovery capital, they have developed recovery capital, and it's a lifelong commitment. So that's a little bit more in depth in terms of what the key characteristics are in the stages of change. And so, what do we want to focus on? How do we move people from one stage to the next in a competent manner? So, from pre-contemplation to contemplation, what we're focusing on is building readiness. And so, what does that look like? We need to take time and care to do the following: to establish rapport and trust with people. We need to explore events that precipitated treatment entry or entry into treatment. We need to always commend clients for entering treatment, regardless of how they got there. If they were coerced, if they were voluntary, other situations landed them there. We should always commend them for, taking the first steps. For coerced individuals, we need to normalize the referral process. I know that you were referred to me by your probation officer, and I know that you're concerned about probation, but and that's fine. Um, but really, I am interested in you getting better so that you never have problems again with probation. And I know that that must be frustrating for you. As examples of what I use to talk to people about normalizing the referral process, we need to honor the client's anger and sense of dehumanization, particularly if they have been forced to do something that they did not want to do. And so to honor that is not to condone negative behavior, is to acknowledge that, you're in a difficult situation. And I, as the provider, I, as the counselor, the clinician, I understand what's going on with you. Avoid assumptions about the type of treatment needed. And here, requires a lot of flexibility because there are multiple pathways of recovery. And sometimes we think that my way is the best way. And, you know, there are 23 million people estimated to be in recovery in the US, and every single person used their own unique way of getting better. And so we need to honor that by way of not assuming that everyone needs the same thing. And we also need to make it clear that the clinician will help the client derive what the client perceives is needed and useful out of their time together. In other words, this is a collaborative process, and I'm here to support you in this process. But you need to take charge and responsibility, and I, as the clinician, counselor, provider, will take charge of the things that I'm responsible for. And so here's another one of those discussion questions. And in the pre-contemplation stage, most people are not thinking about making changes. Mark A for true, B for false. Thank you for completing that question. We're going to move forward. So now moving people from contemplation to preparation. And here what we want to focus on is increasing commitment. How do we help people increase their commitment? And moving from that contemplation to preparation. Remember that in this stage of contemplation, people are already aware that they have a problem. And in preparation, they start thinking about, okay, what do I do in preparation to deal with this problem? So one of the things to think about is moving from extrinsic to intrinsic motivation for change. So what do we recommend there? Show curiosity about the client. Ask them where they're from. Engage in a conversation of getting to know them a little bit more. What are their likes? What are their dislikes? What's their pathway in life? What's their culture look like? What is their family makeup look like? Where do they live? What are their experiences? Develop trust and rapport in many different ways by showing curiosity about who they are. Don't wait for the client to talk spontaneously about their troubles or capabilities. Remember that, many of our folks, this is a total shift from what is normal to them. Um, and maybe what's normal to them is not to be talking about their troubles or their capabilities. Maybe what's normal to them is to have other types of conversations that glorify substance use disorder. So it's important for us to don't not to wait and to engage people in conversations that's participatory. By that, I don't mean that we lecture people. It's to have a conversation with, not at. Um, we need to identify the client's skills and knowledge. Most, if not all of the people that we work with have a lot of knowledge and a lot of skills. They have just been involved with substance use disorders, and for many of them, they haven't thought about themselves as really skillful or knowledgeable. But they do possess a lot of knowledge. I often tell people, could you um, live under a bridge? What does it take to be able to do that? The strength, the skills to survive on the street, the skills to survive in prison. Could we do that? So our folks come to us with a lot of skills and a lot of knowledge. We just need to pick those out and remind ourselves that they're there. Um, Reframe the client's negative statements. Many of the people that I work with have a lot of negative things to say about everything. I don't like this, I don't like that. I've had difficulties with this, or I've never been able to do that. And we need to reframe those things from what's not possible to what is possible. And how do you go from, I'm here because probation, parole, or jail, or my family, or my girlfriend, boyfriend, what have you, forced me to be here, to I am here because I want to be here. And that is possible. We can do that. I myself experienced that um, in treatment with having really good people in my life. I went from prison to treatment not because I wanted to, but because I was forced to. Now, once I got there, what happened there by way of people helping me with the change process is that, a month to a month and a half to being in treatment, and I am talking 30 years ago, I said, I'm here because I want to be here. My motivation for change um, includes many of the things of not wanting to go to jail ever again, but it's because I want to be a better person. I want to be a better family member. I want to be a better individual. And so reframing and moving people forward becomes really important. Start with the client's current situation and find a natural link between external and intrinsic motivators. Again, for me, it started with being in prison. And so soon I moved from that for saying I never want to be in prison again. So I cannot continue with the behaviors that I had. But also because of my health, because of my emotional health, because of my psychological health, because of my relationship with families, and all those things are interconnected for the people that we work with. So in terms of motivating change, we would recommend that. So what about from preparation to the action stage? Now people are prepared and they're going from that preparation stage into action. And so how do we get them started? The context here is the context and some of the strategies to be a vocal fervor about change is not necessarily a sign of determination of change. In other words, people who are saying, "Oh, I want to change," that doesn't necessarily mean that they want it or even understand it. So be aware of that. Sometimes our language doesn't match our actions or intents. We need to focus on autonomy and self-determination. I see you're ready for change. How would you like to proceed? In other words, allowing the person to select their own pathway and what they're willing to do. Because if they're just changing because I'm asking them or forcing them, that's not going to be very sustainable over time. We need to identify resources because that is extremely important. If people are to get better, they will need multiple resources. And maybe in my program, we have some resources, but no one program, no one individual can be all things to all people. So we need to think about it in in partnering with other organizations and resources to be able to do that. And then we should always remember readiness doesn't always mean access. Assist with meaningful access. And so you can be ready to go into treatment and you can be ready for change, but if treatment is not available, then what do you do with people? If there's a long waiting list, or for the many reasons, maybe you're a female, you have kids, and you can't get in because the program doesn't allow for kids. Maybe you're monolingual Spanish and you can't get in because of language barriers. So people might be ready, but access might not always be there. And so those of us who are providers, by way of facilitating change, we should think about our role as advocates in helping people move along. Now, from action to maintenance, and this is stabilizing change. And what Prochaska and Di Clemente said here is that maintenance is not an absence of change, but the continuance of change. And so, you know, we're in that action stage, and now we're getting things, back together in life and that sort of thing. And so, what does it take to maintain those things over time, over a lifetime? And the context and strategies here are the following. At this stage, the client has achieved initial goals and is working to maintain these gains. And so we should be there, supportive, understanding in terms of what's happening with people. We need to acknowledge that sustaining behavior change can be difficult, yet extremely rewarding, always ending in the positive, right? Glass half full. The rewards, yes, it's challenging, but the rewards are a huge payoff. We need to recognize that other areas left unexplored by the client might resurface and cause doubt. And some of those things can also cause relapse. So, always focusing on wellness and a relapse um, makes important sense. Emphasize the client's strengths, progress, and hard work. Be strength based. And how many people have you ever spoken to about a problem that you have that you want to, resolve, and they go to saying, "Oh, that's really difficult. You're never going to be able to do this. You're never going to be able to do that." Or I did that, and it was almost impossible. We want to not become those people. We do not want to become the people who tell people what they can't do. We want to be the champions for people in terms of what they can do, and we want to model that, and we want our clients to seek out people who help them do just that. So, what about this whole term of recovery capital and the change process? And if you haven't read William White's paper on recovery capital, again, I'm going to mention it again, williamwhitepapers.com. The papers there are free of charge. There's a number of them, and there's one on recovery capital. I'm going to take us through some slides very quickly here. Recovery capital is the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from substance use disorders. Recovery capital is conceptually linked to natural recovery, solution-focused therapy, strength-based case management, recovery management, resilience, and protective factors in the ideas of hardiness, wellness, and global health. There are several types of recovery capital that can be influenced by professionals. Again, this is more of William White's work. And so you see William here being very strength-based in terms of what he's encouraging us to do. And so personal recovery capital can be divided into two areas, physical and human. And these two forms of capital are critical for recovery processes and change processes. So in terms of physical recovery capital, what are we talking about? We're talking about physical health. We're talking about financial assets, health insurance, a safe and recovery conducive place to live, clothing, food, and we're also talking about access to transportation. So those are physical forms of recovery capital. If people don't have access to these, gaining and sustaining recovery over time is going to be that much more difficult. So in terms of change agents, we need to increase recovery capital in these areas. So the other one was human recovery capital. Let's look at what those are. Those are values, and we all have values, good or bad or indifferent. We have values. But what we want to increase are the right values. We want to increase knowledge about substance use disorders and the disease model and treatment and those sorts of things. Education, vocational skills, and credentials. So think about it. People want to be carpenters. They want to be counselors. They want to be electricians, they want to be a number of different things. So what are the skills that are needed and credentials that are needed to move along those processes of um, meaningful employment, meaningful participation in society, problem solving capacities. We all know of the people who something happens and they, are thrown through many loops and they can't function. What we want to promote is that people develop problem solving skills and capacities to do better. We want people to have a self awareness about themselves. How do I react to certain situations? How should I react? Um, how am I under pressure? How am I when I'm doing well? So to have a self-awareness is really important in recovery. To have self-efficacy, this is my ability to speak up for myself, to talk about what's right, what's wrong, to advocate for myself, um, to be a vocal participant in my own recovery. This healthy self-esteem, and we all know people who have self-esteem that is not that healthy or low self-esteem. And so what we want to promote is the right type of healthy self-esteem amongst people. Hopefulness and optimism is another form of capital, right? We've all met the people who are always really hopeful. Yes, regardless of what has happened to me, I can get better. Or the people who promote change by way of saying, regardless of what has happened to you, I believe that you can get better. I'm an optimist about tomorrow and about today, and things will get better. Um, the perception of past, present, and future, we can do nothing about the past. We can do a hell of a lot about our present situation, which will impact the future moving forward. A sense of meaning and purpose, a sense of meaning and purpose. So that's my connection to others. That's my connection to why I do what I do on a daily basis. And if I have that, people in recovery are always talking about wanting to give back. That's purpose. That's meaning. That's being. Um, that's having meaning in life. And so, if we create those opportunities for people to give back, we will help them develop recovery capital and interpersonal skills. So that's my ability to interact in a healthy way with other people in my life. And if I don't have that, there will be no mutuality. There will be no ability to relate to others and to work with others in terms of getting better. And let us never forget that no one recovers in isolation. And so we need to also think about augmenting stages of change. So what else do I add to my skill set, to my tool belt, to help people change? The strength-based approaches that I've been talking about during this webinar, in other words, resiliency, self-efficacy, life experiences as a map, etc., all of those things become important. So if you haven't taken a training on being strength-based and strength-based approaches, think about taking some training, interacting with colleagues, and incorporating those into your service and practice. Motivational interviewing is a client-centered counseling style for eliciting behavior change um, by helping clients to explore and resolve ambivalence. And so MI is not a technique that is used on people, but instead used as a way of relating to the client. The overall goal is to increase intrinsic motivation instead of extrinsic motivations. And I was talking about that earlier. So motivational interviewing, wonderful techniques to do with people, to engage with people, makes us better human beings, and makes us better counselors and clinicians. And more importantly, it enables change, meaningful change to take place within individuals, families, and communities. Having a person-centered approach, active listening, unconditional positive regard. Um, when I say unconditional positive regard, really what we mean is I believe in you regardless of your circumstances. I believe in you even at times when you don't believe in yourself. I'm going to be there. And just know that in and of itself is a huge thing that we can do for people in recovery. And being centered comes from that um, line of thought. Recovery focused approaches, so multiple pathways of recovery and our roles within them. And so for many, many, many years, we've said to people, if you want to get better, you need to come to me and see me because I know the way. And you have to do it my way. And if you don't succeed at my way, then it's your fault. And so this is a call for us to think about it in a different way. There are multiple pathways of recovery, and we should put as many options in front of people as possible, and they get to choose what they're willing to do, and we get to support them. And if you do not believe in any particular pathway of recovery, I'm not asking you to believe in it. I'm asking you then to just move out of the way. If you can't support something, do not stop it from happening. Do not hinder it from happening. And if you can support it, then that's fine. And the only way that I've known how to learn and grow by way of supporting these pieces is for me to be um, in training and to learn more about, other perspectives. So augmenting stages of change become really important. We've come to the end of the webinar. I want to thank you a great deal for taking in the information in this webinar, and I hope that it will be of use to you as a professional, and it will be of use to you in helping folks at the individual, family, and community level. So with that, I want to thank you very much for your participation, and we hopefully will hear you, see you at another training event.